Everyone, and welcome to this presentation. I'm going to focus on papers that are about that you can access freely. But before I start on that, I would like to start by asking the question of what is the evidence that we look for? And you can see that I've got the star next to the systematic reviews. If we look at the bottom of this triangle, editorials and expert opinion, case scenarios, case reports, case control studies, cohort studies, randomized controlled trial, and then systematic reviews. Systematic reviews is the peak. That's what we're really looking for. But to be honest, you're not going to find them. As was said, I did do quite a bit of study and certainly worked with people overseas. And the problem with trying to do double-blind randomized controlled trials is that you're never getting enough in your numbers needed to treat with the same medical histories and same medication. So you never get exactly the same patient. These human beings are all very different. And so patching them into boxes so that you can then put them into the inclusion and the exclusion criteria, like you can see on this screen here. This is for another study, but you can see that they've got all their inclusion criteria here, and trying to match that in wound care has been extremely difficult. And so when we talk to our colleagues in the medical world, they're wanting to see double-blind randomized controlled trials or systematic reviews of those randomized controlled trials, and really they're not available. So what do we use? We use best practice documents, consensus documents, which are really, they're worldwide. We get together with this wonderful internet. We can all be talking to each other on a document. Tonight I have a meeting with the World Health Organization. We're working on a document together. We've already put our feedback in, and then we'll discuss the document all tonight. And there's about 27 of us from all over the world on this meeting tonight. And that's really what we're looking at, or clinical practice guidelines. So where do I suggest that you go looking for these documents? I suggest that you look at these websites. So the top one, that's the European Wound Management Association. It is a brilliant website. Oh, and I should also say, with all of these websites, you don't pay any money, but you do have to give them your email address. And then they won't annoy you like Katie's or David Jones or any of those people. Once you give them your address, you're not hassled by them, but they will send you about every quarter an update on what has been loaded up onto the website. What's the newest document that they've put up there? So top one, European Wound Management Association. So that's all of Europe. There are amazing documents there, and we're going to go through some of those today. The Wound Infection Institute. If you are a wound clinician, if you're a clinician managing wounds, this is your Bible. And it is something that I would say that all registered nurses and ideally all doctors would read. Wounds International, that is a group that broke away from the European Wound Management Association because EWMA is Europe. And of course, the Americans would like to do something different, and the Canadians. And so Wound International was formed. Still an excellent group of people. Wounds Me, not so well known, but can have some specifics. Woundpedia, Worldwide Wounds, and Global Wound Academy. For those of you who are in Victoria, I would say to you that if you join the Facebook group, Regional Wounds Group, they have their own documents as well. They have their own research documents that they've done. And they also post a question with a picture of a wound and say, you know, what would you do with this? And then people write back. And so you're in this discussion forum. That's a brilliant way to learn and to also not feel isolated, because that's one of the things as a practice nurse, you're often working alone. And so this group are really, really friendly, happy, and very, very welcoming to share. So here's the Wound Infection Institute document that I really, really do believe that you should all read. It used to be a smallish document. It is very easy to read, but in 2022 it grew. So it currently is about 64 pages. So it's quite big. But look, it is easy to read. And the nice thing is that on every page, there's a little key box that says, well, if you don't read the whole page, at least these are the key items that are mentioned on this page. So invaluable. Now, within that document, they talk about the wound infection continuum. And this is what we all have to understand. We talk about contaminated wounds, colonized wounds, locally infected wounds, spreading infection, and systemic infection. And if you have a look under these headings, you'll see that when you're down in the contaminated, colonized end, you don't require antimicrobials. Under the local infection, you require topical antimicrobials. And once you start to move towards that spreading infection or systemic infection, you need systemic and topical antimicrobials. And this is often where a mistake is made. They still do say you need to use your clinical judgment. So that's still always a very valid thing. And also need to understand that biofilms do start developing down at this colonized local infection end. So here's the chart from the old document. It's easier to read on this slide than in the new document, because the new one is really quite comprehensive. But here are the characteristics that you are looking for in local infection. Now, when you read those, or your GP reads those, the first thing the GP will do is order antibiotics. And you may agree with that. But if you read these and you also read the document, it says that when we think it is locally infected, we should locally treat it, and we don't need systemic antibiotics. So this is where the controversy is lying all the time. Do I do antibiotics or do I not? Now, in preparation for some other work that's happening this weekend that I'm involved in, which is the Australian Wound and Skin Alliance summer school, we're going to be running summer schools now for people of a higher level who want to push themselves beyond the boundaries. It's very limited. Anyway, in preparation for that meeting that we're having, I've obviously been reading a number of documents, and it is still okay when you have an acute wound that you do use antibiotics. So everyone still agrees that if I was to fall over on the road now and get a nasty, deep gash on my leg, the chances are that is going to get infected. So we'll have a good clean of the wound, we'll use the antimicrobials, and yes, we'll have prophylactic antibiotics. So that is still acceptable in the acute scenarios. So please let me sort of highlight that. And the document will highlight that, as well as there are many other papers out there. Now, ideally, we pick up on these points early and can follow the recommended wound continuum. So when we look at this, you know, hypergranulation, something that I can't stand. And once upon a time, we would say it's just because of dressing. So if you're using occlusive dressings, you may actually stimulate hypergranulation. But now they're saying it's such poor quality tissue, there's a chance that that hypergranulation actually contains those microorganisms that are going to start to build that biofilm. And so they've put it under the category of it needs a topical antimicrobial. Some of the other things that are under the local infection, you will also fully understand and comprehend, but it's local we want to do. So again, seeing it from the document, the microbial challenges in the wound healing increase as we move towards that spreading infection and then systemic infection. So we need to increase our activities. So when it's contaminated, colonized, a good clean and a correct dressing, and you should be all right. But when you're in the local, you need a very good clean and topical antimicrobials. So what are some of the topical antimicrobials that are out there? And of course, there are many, all right? And I don't have them all listed on here, but in your question time, you're more than welcome to put in the questions, type them in now, and the girls will get back to me. We will allow time at the end to answer these questions. But the most common that I would see in general practice and community care settings would be the iodine products, so the iodosorb or the inodine. And then, of course, we have the Flaminal, the Sorbact compress, and anything that has silver in it, maybe not so prevalent because it can be expensive, but we all know silver. And I'm just thinking of another one that could have been added in some settings, is you could have had honey on there. Because in some places, yes, honey is used quite widely. So we'll discuss your antimicrobials towards the end, but you should know what are the most common antimicrobials available to you. Now, what is all this information and talk about the biofilm? Biofilms, the discussion around them is expanding. They've probably been discussed for about the last 15 years now, and they keep changing the terminology and the description of them. Excuse me. They keep changing that terminology. Now, we as clinicians, we will say we can see a biofilm. So we see this disgusting, slimy, wet tissue, and we think this is the biofilm, but it's not. The scientists will tell us that the biofilm is actually underneath the surface of the wound. It's about 0.4 millimeters below the wound surface. And so what we are seeing, we as clinicians, when we say, oh, that's got to be a biofilm, what we're seeing is the result of having a biofilm. So are they a bad thing? Well, we're still learning that too, because biofilms have been around for a long time. So we're still learning it, but it does seem to be that if you have a biofilm in a wound, the chances are your wound is likely to become more chronic or slow to heal. I've put this product up here as a separate product to talk about. And why did I do that when I've already mentioned some of the other antimicrobials? I've put this up because it's readily available at the pharmacy. And in general practice, that's quite a good idea to be able to send your patient down to the pharmacy to buy this product. So it's sold in pharmacy by a company called Oroderm. It's called Blast X. It is a very gentle, almost natural product. It has broad spectrum coverage. It has been shown to be effective against Pseudomonas and Staph aureus. It kills planktonic bacteria and destroys biofilm. And there's no evidence of bacterial or phenotypic resistance. And so that's quite good. It's relatively inexpensive. So I've kind of pulled one out. It's relatively new too. Some of you may not know it. But this product is certainly available in pharmacies, most pharmacies. I think the company started looking at Terry White pharmacies first. So if you have one of those, you're probably able to get it. But otherwise, you can, again, look up Oroderm and contact a rep and find out where the nearest place is that sells it in your area. So what are the common mistakes? Well, it's prescribing antibiotics when the wound is inflamed and locally infected. It's not cleaning the wound, and that's the biggest problem that I, as a wound clinician, have, is that nurses are not cleaning wounds. They're literally anointing the wound with normal saline. And they're not identifying the exudate from the dressing and removing the exudate. So if you use iodosorb, for example, iodosorb turns into a soft mashed potato mush in the wound. And some people look at it and go, oh my God, that's pus. But it's not, it's the residue from the dressing. And you've got to remove all of that before you reapply fresh iodosorb. So that's a common error. What do you expect when you are using these products? It's very important to know that. So as I've mentioned, the iodosorb goes like mashed potato. The inodine loses its colour. The Sorbact may actually have, it draws all the microorganisms to itself, and those microorganisms get stuck on the green Sorbact. And so it can have a slimy appearance. The Aquacel or any of those gelling silver fibres will be gluggy and quite swollen because their job is to soak up the fluid. They may even have a very slight malodor. And Measalt, for example, will be slimy because it's sucking all that rubbish off the wound. So cleaning wounds then. What's available? You know some of these products that are on the screen, and there are more coming. So normal saline, one of the papers I was reading yesterday, really says it's good for cleaning eyes, and that's about it. So look, if you're worried about a wound, use something more than normal saline. Prontosan's been around for a long time and certainly has biofilm activity in some papers, and yet in other papers they've been quite critical of it. But it's been around for a long time, so you all know that. One of the papers that I did read said that it needed to be on for a minimum of 15 minutes, whereas the company is now saying they have evidence that you don't need to leave it on that long. So it's probably best that you talk to your representative who has and selling Prontosan. The octenolin is gaining a foothold in the wound cleansing environment. Microdacin, probably not seeing as much of that now because another company bought out that company and is now selling granudacin, but they're very similar products. Of course, I'm a povidone iodine person. I love betadine. That's a brand name, but it is povidone iodine. And one of the reasons I like it is because we're finding that many of our wounds have fungi in them. And so it is antifungal. Some of the other products are not. They're just gram-negative and gram-positive activity. And of course, chlorhexidine. There are still people out there who love chlorhexidine. And the thing about the chlorhexidine is that it really depends on who trained you. If you trained under the Americans, they all love chlorhexidine. If you trained under the English, then you're povidone iodine users. But essentially, is there any one better than the other? Possibly not. The big thing about chlorhexidine too, though, is that there are higher sensitivities with it. And again, of course, it's not antifungal. So a new document that came out some time ago, and I've listed the 2 websites that you can get this document from. You can get it from the Convatec representative, or go to the Convatec website, or you can go to woundhygiene.com, the website itself. So this document was put together with a education supporting grant from Convatec. It's not Convatec biased at all, but it essentially is starting to talk about getting the wound clean and knowing the difference between cleaning and debridement, and the value of both of those. This is an invaluable document as well as that infection document. And that's why they're both up front in this presentation, because these are 2 really, really good documents to read. So they talk about cleaning the wound, debriding the wound, refashioning the wound edge. Now that's new terminology. Literally, we must remove all the serocrusts from the edge of the wound. If you have callus around the edge of the wound, you must remove it, and they will explain why. And then finally, to dress the wound. In the context of the antiseptics that are out there, here is, and this is from some of the reading that I just recently did, looking at all the things that are available, in the past, such as hydrogen peroxide and alcohol and povidone iodine, etc. They were all worried about toxicity. Conversely, now there's a consensus that normal saline doesn't seem to be doing the job either. And so I said to you, really only if the wound is clean. But recently published consensus on wound hygiene says that you need to approach the wounds that have deviated from the normal healing trajectory with early and proactive biofilm management strategies. So we're really encouraging you to think about this and think about the elderly, the immune compromised. Think about the patient who's probably going to get a wound infection if we don't do good cleaning. So from a document that I was reading, it goes on to talk about here, what normal saline is versus hypertonic saline. And while I was doing some Google researching, I actually found that there's quite a number available of hypertonic saline solutions, which is very interesting because I haven't used any of these, even though they are on the Google. But that would be something that I'm heading off to Bangladesh soon to do some volunteer work, and that really would be quite handy to have some of those products up there. We make up our own hypertonic solution when I'm in these resource poor communities. Potable tap water, of course, polyhexamethylene biguanide, and then superoxidized solutions such as hypochlorous acid and sodium hypochlorite. And you can see the variations and the comments on those. So this document is available from Wounds International, and so that's one of the websites I gave you. And it's the use of antiseptics in practice, managing the challenges and the risks of infection in wound care, the use of different antiseptics in practice, wound cleansing and tips for best practice. And it goes back then to quote the wound hygiene document. This is relatively new. This came out last year. Guidance and pathways for antiseptic use, and the importance of antimicrobial stewardship with a focused approach. So the debate, the use of antiseptics to prevent and treat wound infection has been explored for a long, long time. And due to the rapid spread of multi-resistant organisms and the rising emergence of multi-drug resistant bacteria, really, we've got to start to be judicious with the use of our antiseptics and our antimicrobial agents. And so they're advocating the responsible use and preserve their effectiveness for generations to come as crucial. So the do's and don'ts in using antiseptics: you should not overuse them. Now, I may be accused of overusing them, but the clients that I am managing, because I work mostly now in aged care, they're already compromised. You know, they're not always eating well, they're frail, elderly. And so, you know, I'm considering that host. You've got to have a strong host to be able to manage the microorganisms that may overload. So consider that. I mean, I pull back once the wound is really healing well in most environments. Don't ignore the signs of adverse reactions to an antiseptic and make sure to adjust treatment as necessary. Don't use antiseptics as a substitute for proper wound cleansing and debridement, and don't mix different antiseptics, as this can lead to adverse reactions and reduced effectiveness. And then the do's are over there. You know, do consider the allergy status, do wash your hands, do wear gloves when appropriate, and do monitor. So this is just from, I think it's from that same document, a multimodal approach to the various antiseptics and antimicrobials that are out there, and looking at the wounds. So this is a nice chart for you to have a look at in the traditional systems involving multidisciplinary teams to identify the infection, stop use of unnecessary broad spectrum antibiotics, used wound dressings with a physical mode of action, such as meat salt, for example. We know it sucks, and so it's great at removing microorganisms and slough and muck from the wound. So this is a nice one to look at. Now, leading on from that, though, of course, you've got to then start to think about the exudate. And this is a brilliant document. It was redone some time ago. So it's actually been put together by people from the World Union of Wound Healing Societies. And then when they launched this several years ago now, they actually had videos that you could watch, or webinars that we all attended. So you might find those still available or posted on the Wounds International website. But when you think a wound is infected, don't use an occlusive or semi-occlusive dressing. So no plastic, no silicone products. It's a real common mistake. Slapping Mepilex border on a wound that you're worried about and the patient's on antibiotics, don't put it on it. You're only going to cook, you're incubating the microorganisms that are there. Of course, if wounds are infected and they have a high volume of exudate, then you need to choose a product that's going to suck that up and lock that exudate away and stop those microorganisms from re-entering the wound. So you have to fully understand the absorbency of your products, the way in which the fluid is locked away, and what happens to those microorganisms that are locked in that fluid. But definitely no plastic when you think a wound is infected. Please read that document, because in there they have charts such as this, or tables such as this, which will describe the colour of the fluid and what may be the possible cause for that colour. And then in another section, it will tell you what you should be doing for those problems. So, and excellent, I really like this document. So not all super absorbent dressings are the same. So I've listed some on the screen here. Of course, we all know Zejuvit Plus. It's probably the most common one out there. Avliwazorb Pro, very difficult to pronounce. That's from Lohmann and Rauscher. Mextra from Mernlicher. The Bare Medical, the Impervia, the Revello, and the Keep It Simple. And there are others. I guess my message to you is you should know the product that you are selecting as a super absorber. The next paper is old. I'm attending the European Wound Management Conference this year. I suspect that a new paper will be coming out because this paper is very old. My colleague Nikki Frescos has published a number of papers in various journals on systematic reviews of pain documents, etc. But this is the document that did come from the World Union and is also available on the Wounds International website. And it is talking about minimising pain at wound dressing related procedures. And again, that consensus document that I mentioned, that they're really our evidence-based documents. So assume all wounds are painful. Over time, wounds may become more painful, except that the skin surrounding the wound can become very sensitive, and except that for some patients, just simply touching the wound or air passing over the wound, so that's those terrible neuropathic pains, it can be intensely painful. So there are various forms of pain, and also know how to measure this pain and refer on to a specialist when able. The sad thing is we have many specialists out there for pain in the back or pain in the hip, but very few who concentrate on wound pain, and that's sad. There are pain scores out there, and you can use these. So they're mentioned in various pain documents. But personally, and I'm not sure if this will come through well, I had a problem doing it, but I quite like to use tables. I like to chart, like a graph, the pain, and I ask the doctor, so what is acceptable pain for this procedure? Or what is acceptable pain for this type of wound? And if he draws a line across, and then I can say, well, the patient's always above the line, so therefore we're not giving enough analgesia. A visual of the pain is really, really more meaningful to many GPs than just saying, oh, it's 6 out of 10, etc. I think a visual sometimes has more impact. It's in my opinion, and I need to preface that with it is my opinion, but I've had dealings with the Royal Commission, and I think they've done us an injustice. They have listened to families and relatives complaining that by mum having analgesia, she's sedated, and there's been a knee-jerk reaction to this, and so consequently GPs are almost frightened to order appropriate analgesia now. I work in aged care and I see people suffering every day, and a lot of it is because the family won't allow adequate analgesia. Yes, if you give adequate analgesia, the resident may become sedated, but is it not better that they're comfortable? But that's my personal opinion. You may all have an opinion on that, but we need to get on the side of our GPs and get these analgesias ordered. Because the other thing you have to think about is it healable? So is it inoperable, non-healable, or is it actually a palliative wound? So getting that diagnosis right is a problem. We don't always get the right diagnosis. So the one on the far left, yes, that is currently it would be classified as an unstageable sacral pressure injury. But is the one in the middle also an unstageable sacral pressure injury because it's on the sacrum? The answer is no, that's actually a rectal cancer. And then the one on the far right is actually someone who has arterial disease. So not all leg ulcers are leg ulcers. They are located on the leg, but what is the pathology of it? What is the etiology? And we don't always get this right. It's just labelled an ulcer. So when it comes to wound assessment, This is a brilliant document. Now, it was supported by an educational grant from Coloplast, so you will get it through your Coloplast representative, but it's also available on the net. And this is wound and skin assessment, and it shows very clearly, what we're looking at. We're looking at the peri-wound skin, the wound edge, and the wound bed itself. But then it also goes on to talk about the various classifications of wounds in the leg ulcer section and the pressure injury section. This document's from the World Union of Wound Healing Societies, but available on the Wounds International website. And it's very similar to the document that I just showed you from Coloplast. So they are very, very similar, looking at the triangle of wound assessment, assessing venous leg ulcers, and then looking at diabetic foot ulcers. So the document from the World Union of Wound Healing Societies will say, assess the patient, assess all of these other factors that you can see there, going around right down to number 7 with managing the exudate and related problems. So our assessment is vital, and we need to know that we're all assessing the same thing. So terminology is very important. So during COVID, this document came out. I can't remember if this is 21, 22, or maybe, no, it wasn't last year, so 21 or 22. These are strategies to reduce practice variation in wound assessment and management. And it's the TIME Clinical Decision Support Tool available from Wounds International. So you all know TIME. It's been pushed out there by many companies. It's not actually owned by the companies. It is one of these collaborative groups that has put TIME together. And of course, there's many versions of TIME now. There's Timed and Timed S and Timed R, Time R. So there's many of these with these added initials on the end. But this particular tool is quite good when you're in a clinical practice setting. And so how to reduce this practice variation? Well, you need to certainly be looking at, I can't actually on my own screen see the top thing here, but whatever that top one says, then improve the skills of all health professionals who encounter wounds, implement consistently evidence-based approaches, share best practice documents with professionals so that we're all on the same page, and support patient engagement in evidence-based best practice. So here's your TIME, which you all know. So T stands for tissue, is it viable or non-viable? I is for inflammation or infection. M is for moisture balance, so not too dry, not too wet. And E is for the edge of the wound. Is it advancing or non-advancing? In fact, does it look normal? Is it rolled? There are a whole heap of descriptors under E. Some people use the E also for exudate. With regard to patient involvement, these two documents are available from Wounds International. So you have the World Union of Wound Healing Societies document saying optimizing wound management through patient involvement. And then you also have the other best practice statement. As you know, I'm on this World Health Organization group, and the World Health Organization recognizes that we will not have enough health professionals to manage all the people who have wounds or have other things as well. And so they are really, really on the path of encouraging patients to care for themselves. So self-care is a really, really important aspect in wound management. And even when I ran my own clinic, I would sort of share the patient. So I would teach the patient how to do their own dressing, and then they would come back usually twice a week for me to monitor. And then as it was getting better, they would do one dressing once and I would do one within the week. So share care is very, very important. I'm currently sharing a patient with a plastic surgeon, a hand surgeon, and myself involved in the patient care. And it is really important. The patient's actually doing their own dressing as well. I taught him how to do his own dressing last week. So in fact, it's the patient, the plastic surgeon, the hand therapist, and myself. And it is very important that we do shared care. Now, specifics in wounds. There are all kinds of documents out there. Not every wound has a best practice or a consensus document. But skin tears are so common. There are a number of papers out there on best practice recommendations for the prevention and management of skin tears in the elderly or in the vulnerable, because it's not always elderly. It can be the very, very young. You know, our neonates, for example, we put tubes in their nose and tape on their face, and when you take it off, there's damage. So we do need to know how to prevent, what are the best products to use and what are the safest to use. And sometimes non-adhesive is better. And then how do you retain that? So for the elderly, thinking about things like those Tubifasts or tubular band to hold a dressing on rather than adhesives is vital. With regard to pressure injuries, this is the international guide. It came out in 2019. It's actually going to be discussed at the European Wound Conference. So there'll be some new terminologies coming out. We have been debating a thing called the Kennedy ulcer for a couple of years. Is it the Kennedy ulcer? Is it an end-of-life ulcer? Is it a skin failure? What is the language that we're going to use when someone is not eating, is slowly dying from the inside out, and their skin is breaking down despite everybody's best intentions? So that will come up in this meeting that I'm going to be attending later in the year. And so you will probably see a new international pressure injury document come out very soon. Of course, this could be controversial. This is the role of dressings in pressure ulcer prevention. I call it pressure ulcer there. As you know, in Australia, we call them pressure injuries. And the world has now changed. So this document, when it's redone, will be called pressure injury prevention. Look, they will come out and eventually they will be saying to you that the dressing has no role in preventing pressure, but it may have some role in promoting stronger skin so that the shear and the friction and the pressure are eliminated. And so you do need to look at it in the broader context of things. So the possible myths listed: dressings indicated for open wounds are not suitable. When a dressing is used for pressure ulcer prevention, no other pressure ulcer management is required. They've challenged all these myths. So in the first one, there are a number of dressings that have been shown to improve skin integrity. In the second one, there is no dressing that says you do not need to reposition a resident. There's no device that says that. Microclimate is a very, very important aspect, and we are learning more and more about the role of temperature and the oxygen demand that skin has when the temperature is higher versus when it's colder, and also the moisture level. So you can see that here from that document. There's the Australian guideline for Australian and New Zealand guideline for the management and prevention of venous leg ulcers. I love the flow chart for this. It's a very old document now, so there are quite a number around from the other websites that I've suggested to you: Wounds UK, the Journal of Wound Care, Wounds International, and even last year the European Wound Management Association put out a new document on the management of venous leg ulcers. Now, with regard to diabetic foot, I would strongly recommend that you visit Diabetes Feet Australia. They have the 2021 evidence-based Australian guidelines for diabetes-related foot disease, and there are 6 modules in that. So you can download it as individual separate modules. So assessment, risk prevention, dressings, infection, offloading, those sorts of things. Brilliant documents and well worth the read. And again, when they launched those, there was a webinar for each of those documents, each of those modules. Now, just to go through what else is available for the European Wound Management Association, there's a brilliant document on atypical wounds, really good read, particularly for you who are working in general practice. You're not going to see just straightforward venous ulcers or straightforward arterial ulcers. And so there are many others out there. This is just going through some of the atypical ulcers that are available, that are seen on lower legs, and what characteristics you may be looking for and how to manage them. Of course, there are oxygen therapy devices now coming out. So we used to always look at hyperbaric oxygen, but now we have topical oxygen therapy devices. So they may be pertinent to your area of practice. Then there are, and there's a meeting on this in a few days' time, on new modalities. So looking at cells and tissue-based therapies, physical and biophysical therapies, smart and IT-based technologies, and then the health economics of these. So you all know that eventually we probably will be doing an awful lot on our mobile phones, and the mobile phone will be alerting us that the temperature of that wound has increased, or the dressing is leaking, you need to replace it. So these technologies are advancing rapidly. There is one on epidermolysis bullosa. If you happen to be managing those people, that's available from Wounds UK, and we'll go through the best practice guidelines for EB. There's one on skin graft donor site management and the treatment of burns and hard to heal wounds. Again, anything that's the World Union of Wound Healing Societies is available on the Wounds International website. And then I'm just wrapping up with a bit on surgical wounds. I'm quite keen on having a look at what's available out there. There's actually a journal now on prevention of surgical wound dehiscence. So this is the international best practice recommendation for the early identification and prevention of surgical complications, that document. And of course, you will also find them on the Wounds International, two documents around surgical wounds, one from the World Union and one from Wounds International. The one that I like the most, though, is the World Health Organization one. It's quite complex, it's large, but given that I volunteer in resource poor communities, I find that a good one. There's just a little note from Wounds International on taking photographs of wounds. So many mistakes are made that I find it very irritating that people can't take a good photo of a wound. Most of the reasons they can't is because the person's already out of bed and they've got the wrong light behind the wound. So planning your photography is vital. So I have time, I think, now to answer any questions. Yes, we do. So I'm happy to stop sharing now and go back, and we will discuss any questions that you have. So over to you, ladies, if you have questions.
Yeah. Thanks, Jane. We've got one here: best dressing for non-healing chronic ulcers with stubborn slough.
Okay, so it's non-healing, you said. What I guess I want to know is, do you think it's possible to heal that wound? And you called it a non-healing ulcer, but it should have a name. So is it a pressure injury, a venous ulcer, an arterial ulcer, a diabetic foot ulcer, a neuropathic ulcer, a Barili ulcer? What is it? So whoever asked that question, if you can type in and give Julie or the others a bit more information, but you will see that there's no answer for that question unless you have more information. Dealing with thick slough, though, mee salt is excellent. Of course, mee salt is 20% salt, so it has to suck. So therefore, you're going to need a very good super absorbent dressing to manage that exudate. And mee salt is prescribed by the manufacturer to be changed daily or more frequently, depending on the circumstances. So what's the answer there? Have you got what it is?
Nothing's come back, Jan, so I'll go on to the next question and we'll wait and see. What would you recommend as antimicrobial
You've just got to scroll up, that's all.
What would you recommend as antimicrobial for people with sensitivity to iodine products?
Okay, so you have that choice. You have Prontosan, microdacin, octenolin, chlorhexidine, granudacin. Yeah, you could start with all of those. So there's a lot in that list. And for those who asked the question, you will have the PowerPoint as a reference for yourselves later. Thank you.
Yeah. Betadine was a no-no many years ago, and why has this changed?
Yeah, okay. Okay, so betadine was a no-no because all antiseptics kill living cells. All antiseptics. So they said, you know, if you put it on a wound, you're going to kill the living cells. Well, just a minute. We want to kill the bacteria that's causing all that muck in the wound. And when we get lovely, healthy granulation tissue, of course, we don't need to use it. So it was, you know, somebody came out with a statement and it took off like fire and everybody thought, shouldn't do it. I didn't. I kept using it because in plastic surgery, we kept using betadine, even though everybody else said don't use it. But we used it appropriately. Use it on sloughy, dirty, yucky wounds. Kill the microorganisms, because if you don't kill them, they'll kill you. And then there's no point in worrying about whether it was killing living cells or not, because you're dead. So, you know, you got to kill the bugs. And so when you read that green antiseptic, the green infection document, you will find that more and more we are looking at povidone iodine. There is no resistance to it. And yet silver, which was brought out as the panacea of all wound infection issues, there is resistance to that now. And it's only been out 15 years. So please read the infection consensus document.
Many years ago, Jan, you recommended just using tap water.
Yes, I did. And I still do wash all my wounds with tap water first. So when I had a wound clinic, I would go and we had disposable face cloths and I'd get some tap water and I'd wash the leg and wash the feet and wash the toes and dry it all. And then I'd start on my wound care. So I guess who asked that question, yes, you've got to clean the peri wound. You've got to clean the skin. We met many people who actually don't have their leg skin washed for months. You've got all the healing comes from the skin, so you've got to care for the skin and then care for the wound. So I would be washing everything as much as possible. I mean, if someone had a sternal wound because they had had open heart surgery, well, I'd wait 72 hours before I let them have a shower, for example. But otherwise, there's very few wounds. I'm looking after a boy with a brain tumour, and, you know, I tell his mum, wash his head in the shower. And then we do the wound care. So yes, I still do use tap water, but it has to be tap water to be safe enough to drink. So where I'm going in Bangladesh, I probably wouldn't be using the water.
How long can you leave flamazine on so it's effective, as the recommendations vary?
Yeah, okay. So flamazine in wound care is not commonly used. And that's because it leaves a pseudo eschar. It leaves a yellow slime on the wound. I know it is used in burns management, but that's because they know that the patient's going to hospital and going to have the entire wound and everything debrided back to a bleeding base. So they take away all that pseudo eschar. In general practice, we don't use the flamazine very much because of the pseudo eschar. The recommendations are that it's changed daily. However, where do we use it in wound care? We use it in palliative wound when we know the patient is dying and we don't want to be at them so much and we don't want that wound to dry out too much. So often it could be used in a palliative wound. And in that scenario, it may be changed second daily. So a patient with all the tendons exposed on their foot and it's really disgusting, we might put this gentle dressing on and change it every 2 days, but it's a palliative sense then.
Is saline appropriate if there's no concern of infection or inflammation?
Yeah, definitely we wouldn't be using it. Is saline appropriate if there's no concern of infection? Yes, it is. Yes. And I can see wounds healing on the elderly with methotrexate. Yeah, methotrexate delays wound healing. We know that. So you need to talk to their rheumatologist and find out if they can have it ceased, if the patient wants ceased for a month, and see if we can kickstart wound healing. But of course, if you take them off the methotrexate and they can't move and they're in pain, then you might have to find other ways to manage that wound, and know that it will be very slow to heal. But methotrexate delays wound healing.
Okay. Can you tell us more about silicone meshes?
Okay, so the old Gelinet was literally Vaseline on gauze, and the problem was that the Vaseline was irregularly dispersed over, and it also stuck, it dried out, and it left fibres. So we started to move away from Gelinet, and we moved into other types of non-stick dressings, such as Cuticerin, Adaptic. And then silicone came into be with the foams, and they realized silicone's tacky but not adhesive. And so those companies then started to develop silicone meshes. You can put a silicone mesh on a skin tear after you've cleaned it and reapproximated the edges. You can pop it on and put your secondary dressing on top, and you can change your secondary dressing once or twice a week, but you can leave your silicone intact for 2 weeks. So in skin tears, they started to progress rapidly, and now of course they're used in many areas. If you had a skin cancer, and you know it's not going to heal and they're not having surgery, then putting the silicone mesh on after cleaning the skin cancer and then a non-stick dressing on top means that each time you change that non-stick dressing, you don't have to change the silicone mesh and traumatize that skin cancer. So they've come a long way, and they are generally seen as products that will protect the tissue underneath.
And this is their first question with the unhealing ulcer. And she said, venous ulcer, I think. It's inflamed, stubborn slough, minimal wound bed visibility, nil pain in an elderly patient.
Okay, so you think it's a venous ulcer. So the first thing then is that you need to make sure that you're using compression therapy, because the gold standard for venous ulcers is some form of compression therapy. So number one, you need compression therapy. If you're using compression therapy, your exudate volume will ease up. So you'll have less exudate, which means you will have less slough. So if I was managing that wound that you were speaking of, I'd probably do iodosil powder on the slough, zinc cream around the venous ulcer, super absorbent pad, something to hold all of that in place, and then toe to knee compression, and change it initially every second day and then move to twice weekly. Patient needs to walk and elevate.
And the wound was on the calf.
Okay, so you don't usually find a venous ulcer on the calf. It's usually in the lower third of the lower leg, known as the gaiter region. But of course, you should be doing your vascular assessment as well. So can you palpate the pulses? Yeah, on the calf, you'd be wanting to check a little bit more, ask more questions about how did it start? Yeah, and feel your pulses. But otherwise, yes, those things I would still do.
Should you use a gel to make Mesolt stick or leave it on dry?
Oh, Mesolt goes on wet, green, yellow slough. So it goes on dry. When Mesolt starts, when you start to pull it off and it's stuck, you need to change to a different product, because it's obviously the wound is not wet. Mesolt's only used on wet wounds. So you might need to use iodosorb on slough, or Flaminal, or one of the silvers or something. But Mesolt's generally, you shouldn't use a gel to make Mesolt stick. It should be sticking on that wet yellow slough. And it needs to be changed every day, and each day you take it off, it's slimy, it's doing its job.
What do you recommend as a dressing after managing a wound with an antimicrobial?
So when you read the infection document, you will find out that if you debride a wound and remove all necrotic tissue, or as much as you can, they always say follow with an antimicrobial. Once you feel that you've managed the microbes in the area, You can use any of those gentle skin, those cleansers that I mentioned previously, like Prontosan or Octenolin as a cleanser. And then really literally, it just depends on the tissue. If you've got no slough, you've got healthy granulation tissue and normal serum exudate, then you can just use a melalin, a non-stick pad, or an absorbent pad.
Okay. When do you consider a wound at a point to swap to dry dressings?
Good question. So you go to dry dressings when you think you've got skin there. So pink, if it's pink. And if when you press it, it wrinkles, that's skin. So you can just use a normal dry protective dressing. Or if the wound is now black due to ischemia, then you're probably not going to heal that wound because dressings don't take blood to the wound. And so we switch over and go, okay, this is non-healable. So we're just going to maintain it dry. The rules for ischemic wounds are if they're dry, keep them dry.
And after your comment about flamazine, what should be used for burn blister wound? We've been using flamazine.
Flaminal. Flaminal is seaweed with 2 active enzymes that kill microbes. It is a water-soluble gel, so it will not leave a scum on your wound. So you won't get that yellow slime on your wound. So Flaminal. Good evidence on Flaminal.
And that's it. Just another comment. Thank you for the great info. So,
good. And we're on time.
Questions. Yep.
Perfect. Okay.
Thank you. Are you okay for me to take over now, Jan?
Thank you.
Fabulous.
Thank you so much, Jan. Great info.
Thank you all for being a part of today's session. It has been an absolute pleasure to have you here this afternoon, and I hope you've taken away some valuable insights. I'd also like to extend a special thank you to our exceptional presenter for their fabulous work. At the end of this session, a link to the workshop survey will appear on your screen. Please do take a moment to fill in the event survey so that we can further improve these education sessions. Your responses are greatly appreciated. Please also take a moment to check out any other upcoming infant education events by scanning the QR code on your screen. It will take you directly to our events page on the infant website, where you'll be able to find out more information about what other workshops we have coming up and to register yourself for one there. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen today, in addition to any other relevant resources. You will also receive your certificates within the next 4 weeks of this session from MFIN. Thank you all for your time today. That is all from us, and have a wonderful rest of the day. Thank you all.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Bye.